Okay, we're going to go ahead and get started, everybody. Thank you for joining us today. Welcome to Reach. If you've not joined us for our other sessions, then welcome. We're going to go over just some housekeeping items real quickly, nothing new, just before we get started here.
Okay, so I can't hear.
Let's see. I'm not able to click through my screen. Okay, here we go. Can everybody see the screen? Sorry, I was having issues last time. Hopefully I won't have issues today. So just some initial disclosures. Again, nothing new. Reach is going to be in tandem with Echo collecting data on participation, chat comments, registration. We're going to be using this data for reports, maps, communication, surveys, quality assurance, evaluations, and just to inform new initiatives. All of this will be kept confidential. For education purposes, we will be recording the sessions and we'll be making those available to you all on our website. You have consented to being recorded. If there's anything that you have questions about, just feel free to reach us at our email. So as a nurse, these sessions are accredited to for continuing education units through LMH PCO. Each session is going to be worth 0.5 units. We will be taking attendance at each session and monitoring engagement. We just ask that you complete a post-session survey that will be sent to you following each session that you attend. So those will be mandatory in order to claim your credit. We all are, I think, familiar with Zoom. So just remember, we welcome you to come off of mute at any point and ask questions or give comments. If you're not speaking, just be mindful of that mute button. Make sure you're muted if not speaking. And then if you're able to keep your camera on, that would be great if possible, if you do have the bandwidth. And then this will be helpful for me in terms of taking attendance. If everybody can click on the top three, at the top right of your screen, there should be 3 dots. If you could just click those and then rename your name with your first name, your last name, and then your hospice organization, that will help me for taking attendance. And then just some ground rules. We invite everyone, like I said, just to, we're in a virtual setting, but as much as possible to create a sense of community, to feel welcome to come off of mute and speak up and share any comments or questions that you have. This is a safe space. We say what's said here stays here. And we encourage you to share comments or share examples from your work situations, and just make sure that you are using de-identified information when you do that. And I'm going to turn it over to Dr. Mo.
Hey y'all, I'm Dr. Morvan. I'm Chief of Pediatric Palliative Care at Children's Hospital New Orleans. We're called the Pelican Crew. I'm also the chair of our Gulf States Pediatric Palliative Care Consortium, working with Marquetta Trice and Jamie Boudreau with Louisiana Mississippi Hospice and Palliative Care Organization. Yes, I could say those things very quickly. So today I'm really excited to talk about our agenda. We're going to start with sort of welcomes and introductions. We're going to review sort of the objectives for Stevia Davis's session. Stevia will lead our didactic presentation, and then we're going to wrap up with some questions and a case study and hopefully dialogue. And then we're going to have Stacy Melling, our integrative therapies nurse, end with a good mindfulness activity. Next slide. All right, so if each of you can introduce yourself with your name, organization, role, and your practice location, that would be great. We're going to start with Cheryl. Unmute, please.
I forget that. I'm Cheryl. I'm the maternal fetal medicine navigator out of Children's.
Thank you. Lisa?
I'm Lisa Baumgartner. I'm the chaplain at Our Lady Lake Children's Hospital.
Awesome. Welcome, Lisa. Judy?
Hi, I'm Judy Zarang. I serve as the nurse spiritual care for our Pelican crew.
Stacy?
Good afternoon. I'm Stacy Melling. I work at Children's Hospital and I'm the integrative therapy nurse there. Work very closely also with the Pelican crew.
Thank you. Cindy?
Hi, I'm Cindy Fowler. I'm the Director of Nursing for St. Tammany Parish Hospice.
Welcome, Cindy. And Christy?
Hi, I'm Christy Heitmeyer. I work for Heart of Hospice, and I am the pediatric nurse consultant for all of our agencies.
Courtney?
Hi, I'm Courtney Kelly. I am the Hospice Clinical Operations Coordinator with LHC Group.
All right. Isabella?
Hi, I'm Isabella Boer. I am with Children's Hospital New Orleans, and I am a Senior Director of Patient Care Services with oversight over our ICUs.
Whoop, whoop. Allison? Celino?
Hi, my name is Agobe Ali. I am the nurse navigator in GI, and I just have an interest in palliative care, so that's why I'm here.
Woohoo! We love that. Lisa?
Hey, this is Lisa Powers. I'm a compliance officer for Sanctuary Hospice in Tupelo, Mississippi.
Welcome. Tammy?
Hey, I'm Tammy Ide. I'm the manager of supportive care services and over the palliative care department for the Baton Rouge market for Our Lady of the Lake.
Awesome. Mary?
Hi, I'm Mary Bowie. I am the director of clinical at Heart of Hospice in Acadiana. We are under LHC Group. I'm also over Lourdes Hospice. And shout out to all the people from Children's. That is where I got my start as a nurse and love that place and still miss it.
Yay. I thought your last name was Bowie. I was going to ask you if you're related to David, but it's Bowie. I would have gotten
Yeah,
that.
I know. My husband corrects everyone all the time.
I'm sure you get that all the time. Marquetta? Marquetta says that she's the education director for Louisiana Mississippi Hospice and Palliative Care Organization. Thank you, Marquetta. All right, next slide. And then I'll introduce Stevia. Do you want me to? I'll introduce Stevia first, and then you could roll into objectives. Is that cool?
That sounds good.
So it's my pleasure and honor to introduce Stevia Davis, who is our fabulous nurse practitioner with the Pelican crew, aka our palliative care service line at Children's Hospital New Orleans. She joined us from Rainbow Babies from Cleveland, Ohio, almost 1.5 years ago. And she accepted her position literally during like Hurricane Ida. Like she still wanted to come after that. So like dedication. She has been an incredible asset and addition to our team. And one of her sort of I think major strengths that she brings to our palliative care program is her understanding of children who are living with severe neurological impairment, in addition to how and what approaches are sort of evidence-based in treating their symptoms, which is these kiddos can come with a lot of different symptoms, a lot of different pain behaviors that are very atypical compared to the typically developing child. So without further ado, let's all welcome Stevia to lead us in discussion today.
All right, thank you for that wonderful introduction, Dr. Mo. So our objectives today, we're going to discuss kind of our top 3 most common neurologic conditions that we see in pediatric palliative care and hospice, and those are delirium, seizures, and then chronic neuro pain. And just with like the little hands emoji at the bottom, how many of y'all have seen one or all of these conditions and work with them? See a hand. Okay. All right. Awesome. So we know it can be very tricky to treat. So we're going to give you some great tips today. So we're going to review our treatment approach for each condition. And as always with palliative care, we're going to have a comprehensive evaluation to identify any underlying causes. We want to discuss the goals of the family so that we're creating a care plan that's in line with their goals of care. And then with that, initiating pharmacologic and non-pharmacologic therapies to help our patients feel better. Next. So delirium, we think of as an acute brain dysfunction. And this diagnosis does require assessment of, and this is where we're having, acute changes or fluctuation in mental status, inattention, or acute alteration of our level of consciousness, or disorganized thinking. We often will see this in the hospital and ICU settings, but it absolutely does happen at home. It does impair function, and it is a very distressing symptom for families to experience with their children. It can be especially challenging to assess delirium in non-neurologically intact children. And then a little subcategory is hyperactive versus hypoactive delirium. Hyperactive can be a little easier to pick up, and hypoactive can be a little bit more challenging. The patient is often quiet or withdrawn and sleepy. So we like to use scales to help us assess for delirium. This is the Richmond Agitation Sedation Scale, RASS. And there are quite a few validated tools out there. This is one that I do like to use. So as you can see, you're just doing, 0, we're alert and calm, we're responding to the caregiver. And you can see the more hyperactive goes up in the scale, and then the hypoactive, you're going in the negatives. And along this, if any of y'all have ever used these scales or have other scales that you like to use, please feel free to unmute or put it in the chat. Another scale that we like to use is the Cornell Assessment of Pediatric Delirium. That's our CAPD. And another scale that we like to use in the PICU, but also can be used in the home setting. And that's going to kind of help us identify our patients that we are concerned may be experiencing delirium. And there will be links at the end of the presentation with these scorings. So on, go back one. This one, we're going into more like the eye contact, about the actions of the child, awareness of surroundings, communication of the needs and wants. And again, if we have children that are not neurologically intact, this can be more difficult to assess, but knowing the child's baseline really helps us with a thorough assessment. Okay, I can go next. So once we've identified our patient with delirium, then we would need to think about what underlying causes could be bringing about this delirium. So brain maps is just a helpful mnemonic to help us think about the etiologies that could be causing the delirium, and they are often multifactorial. Medications are a huge cause of delirium in our pediatric patients, and especially the patients that are on benzos, steroids, opioids, cholinergic, so often the medicines that we are using in palliative and hospice care. So looking at the brain maps, we're thinking about oxygen, the drugs, so like our anticholinergics, our benzodiazepines, the atmosphere, eye infection, immobilization, inflammation, and then new organ dysfunction. And then metabolic disturbances, which can be difficult to assess if our patient is at home and we're not getting labs. The awareness to their environment, so their sleep-wake cycle, pain, and then sedation. Okay. So when we are assessing our delirium, we do need to know and continue to have conversations about our goals of care. So where are we in the patient's trajectory illness, and what are the patient and family's goals right now? And we should always be eliciting those in our conversations so that we can create a care plan that is in line with those goals of care. So if our patient is actively dying and the goal is to remain home, and we find that they are experiencing delirium, then we're not going to be sending them to the ED for an evaluation. We're going to keep them home and manage this at home. If it is within the family's goals to return to the hospital, then we would consider going to the ED or direct hospital admission. And that is the benefit of having concurrent care with our pediatric hospice patients. Next. So after we've done the assessment and we've know the family's goals of care, we can start to initiate some non-pharmacological management. So going through the brain maps, we're going to try to remove any of those underlying causes that we may have identified. Promoting day-night routines is huge and can be especially challenging in the hospital when you're coming in getting vitals, or getting lab sticks all throughout the night. So even if our patients are just a little bit more sleepy, they haven't slept during the night, even leaving the light on or opening up the blinds and they're still going to nap through that, that's okay. It really does help with the sleep-wake cycle. Trying to have consistent schedules with minimized interruptions. Again, when we're in a hospital setting, that's nearly impossible to do. And it can be at home as well, but as consistent as possible. And then orientation cues. So having a clock or a calendar that our patient can see easily and kind of reorienting them to those, to the date and time. And then anything familiar, like maybe a blankie or a stuffed animal that they really like, or music that will help provide some comfort. We also want to minimize the stimulation. So when we are trying to promote that day-night routine and having lights on, we do want to try for natural light over like our overhead artificial light if possible, or like a side lamp. And then trying to have familiar and consistent caregivers. So hopefully we're having primary nursing and you're the same person coming in every time, so minimizes that disruption. Always educating the caregivers on what we're seeing and ways that we can help with this delirium. One-to-one care companion is awesome. I know that a lot of times with the shortage of caregivers, it is difficult to do, but definitely helps with the safety. And then if possible, we want to try to promote mobility and activities. So activities, especially like really getting the interdisciplinary team together, child life, PT, OT, we're lucky enough like integrative therapy, just to get them oriented and doing other things. Okay. When we are thinking about pharmacological management of delirium, we want to try to reduce or remove delirium-inducing medications if that's possible. And often that can be a difficult task. We want to treat any underlying pain or infections that could be causing this delirium. May consider adding on melatonin to promote the sleep-wake cycles. And then also antipsychotics are great for acute delirium treatment. Our most commonly used are the 4 below, so Haldol, Zyprexa, Seroquel, and Risperidol. And then at the end again, we have the Dana-Farber Blue Book, which has a whole section on management of delirium, along with dosing recommendations for antipsychotics. And quick little poll, how many of y'all have used any of these drugs below for management of delirium? And it can be just a little clap again if you have. All right. So another type of delirium that can be experienced is terminal delirium, and that is delirium that occurs at the end of life. And how we consider it in our pediatric patients is significant agitation or suffering despite our aggressive treatment of pain. So if we are at the end of life, we're escalating our pain meds appropriately, and we're still having this agitation or this suffering, then we likely need to be treating delirium. So again, we always want to utilize the non-pharmacologic interventions, and those are really the cornerstone of delirium treatment. Those are going to be the most helpful. And then when we are in the terminal delirium, we lean heavily on pharmacologic management. So using those antipsychotics from the last slide, and we can increase that dosing up to every 1 hour dosing, as well as benzodiazepines. And then this is really, terminal delirium is really the only setting where we would use benzos. Any questions or comments on delirium management, treatment?
I was just going to say that I think pediatric delirium specifically is what studies have shown is that it's extremely underdiagnosed. And sometimes by really assessing and keeping delirium at the top of your differential when children are exhibiting discomfort can be really helpful to improve, especially when time is short, the amount of wakefulness that a child may have, as opposed to just assuming it may be pain or dyspnea or some other symptom that would then require things like more opioid and more benzo approach, which would just make them more sleepy, potentially missing a symptom that could actually allow more wakefulness and meaningfulness for the time that a family does have with their child. And so always keep this in the back of your mind when there's like sudden changes in behaviors and you're not quite sure what it is.
Thank you, Dr. Mo. That's a great point. And that's the RASS scale and the CAPD can be used in the home setting as well, and can be really beneficial. So next we'll move on to seizure management. And as I'm sure we all experience, that many of our pediatric patients who are receiving hospice care do have underlying neurologic conditions or a structural abnormality with a tendency for seizures. And seizures can often become more difficult to control as a child moves more towards the end of their life. Seizures are often very distressing for families to see and for the care teams. And so we want to make sure that we're assessing the seizure risk and then including the plan for management of seizures when we're talking about end of life. And especially at end of life, the organ dysfunction that can accompany end of life with the metabolic abnormalities, and then additionally, any trouble with swallowing, absorbing, or metabolizing the drugs also can make it extremely difficult to manage seizures at end of life. So our patients that are at highest risk for seizures are patients with brain tumors or metastases, structural abnormalities, neurodegenerative conditions, neurometabolic disorders, VP shunts, and underlying seizure disorders. So again, when we are looking at management of seizures, we want to have a comprehensive evaluation to identify any underlying causes and assess what is more or less important as the child is moving towards end of life. Having those goals of care conversations, and especially asking kind of those what if questions with the family before we're hitting that point at end of life where we are having difficulty controlling the seizures. And then we're going to be planning with the hospice physician that we're working with to see what options exist for seizure management in the hospital. You know, we're able to get nearly everything that we need for seizure management, and sometimes when we're in that home setting with hospice, the medications are more difficult to get or were unavailable. So always kind of creating that comprehensive plan ahead of time to try to have the best approach. And some of our what if questions that we might think about when we're looking at managing seizures at home is, you know, what if we can't get reliable IV access? What if we can't obtain the certain medications at home? And then what if we can't get control of our seizures while we're at home? So these are all the things that we want to think about before reaching end of life. And then often our patients will be on, will be under a neurologist's care. And so then working with the neurologist to, you know, come up with a plan, see what we can maximize on the AEDs and adding to that plan. So for our initial management, we want to treat potential triggers if possible. So like seizures, infection that can often lower our seizure threshold. We want to maximize our existing AED dosing if possible, again, working really closely with the child's neurologist to help facilitate that. And then any additional scheduled medications that we can use to help prevent further seizures, and then making sure that we have our rescue or abortive medications as needed. And I always like to maximize the current medication that we have before adding on another scheduled medication. So management at end of life is very highly variable. Common medications that we use: midazolam, diazepam, lorazepam, phenobarbital, and Keppra. Midazolam intranasal, really like to use. Often I will use that as like my third line. I'll go like lorazepam, midazolam, if we are having difficulty breaking a seizure. And sometimes I know midazolam can be difficult to get in the home settings. The intranasal is generally well tolerated, but it does have some burning side effect, just to be aware of. And again, that the Dana-Farber Blue Book has dosing recommendations. Any questions with seizure management?
I was just gonna add that the phenobarbital, I think, is underutilized in the home. It's a very inexpensive drug, and rectally it has really, really great absorption. If your hospice is unable to do a quick intranasal midazolam. Also, phenobarbital lasts a lot longer. It has a calming effect, and it also has been shown to help a little bit with pain as well. And so that's one of the older medications that I think is sometimes underutilized. Although I think what studies do show is that the benzo is the route to go for seizure mitigation for sure. But don't forget about phenobarb.
I have a question. Does it come in a suppository, or do you have to give it through a Macy catheter?
Good question, Christy. So I've been able to get that either the IV or PO version of it and give it rectally, even without a Macy catheter, but a Macy catheter would be ideal.
So how do you get it? You're giving it the liquid or a pill?
It depends on how big the kiddo is. I've done liquid and I've done pills.
So you just insert the syringe and squirt?
Yep.
Okay, cool. I didn't know that.
Yeah, I mean, it's not the most ideal. I think a Macy catheter is the way to go. And if you can do a sub-Q button for all of these, I think that that's a really easy access as well. We don't do enough sub-Q buttons like in our hospices down here. And I can't stress it enough that sub-Q buttons can make such a huge difference in quick
Like a
mitigation.
crisis?
Yeah, a quick mitigation of severe symptoms for sure. I 100% recommend sub-Q buttons too, to be available quickly. What do you think, Stevia?
Yeah, I agree with those recommendations, especially the sub-Q button can be so beneficial and is very underutilized. Any other questions? Okay, then we will move on to chronic neuropain. So our children with severe neurologic impairment are at risk for what we call for chronic pain due to the alteration in their central nervous system. And then we call their chronic pain neuropain. And chronic meaning that it is occurring for greater than 3 months. Neuropain is often very difficult to diagnose, and so then treatment is delayed. And early recognition and screening of these patients is key in relieving the suffering and improving the overall quality of life for the child and the family. So this chart is a little difficult to see, but this is from Julie Hauer. She is an expert in children with severe neurologic impairment. And this is kind of the problems that she goes through when assessing for neuropain. So there are usually several sources for the pain due to the altered nervous system that the child has, and then many of them often overlap with each other. So neuropain is often due to a combination of more than one source. And then I like to call it a diagnosis of exclusion. So because there aren't any tests or really diagnostic criteria for us to evaluate and diagnose this, we have to rule out other potential causes before treating the neuropain. And if y'all can see this, it's like central neuropathic pain, visceral hyperalgesia, chronic post-surgical pain, autonomic dysfunction, dystonia, spasticity, muscle spasms. So those are, as you can see, like often overlapping on each other. Go next. So in the Dana-Farber Blue Book, this is on the left-hand side of the screen. These are pain behaviors that we will often see in patients with severe neurologic impairment. The vocalizations, the crying, the moaning, the facial expressions, often like grimacing, frowning, unable to console like at all, not soothed by what they normally are soothed by. Often they're gonna withdraw and try to seek comfort, and that can present in a variety of ways, but often like wanting to go under their blanket and wanting to really hug their bear more. Physiological, so tachycardia, sweating, paler flush skin, tears. You can also, it can be on either end of the spectrum. It can be tachycardia, it could be bradycardia. Same with our blood pressure. We could have hypertension or hypotension. Sweating, and then the paler flushed, often it's flushing, and you're gonna get like a truncal flushing as well, or what would appear to be a rash. Our muscle tone, you're gonna see a lot of the back arching, you're gonna see the intermittent stiffening of extremities, a lot of clenching of fists, muscle tensing, and sometimes tremors. And then our movement may be increased from baseline. They may be more restless, more startles more easily, pulls away when touched, or twisting. So on the right-hand side of the screen, we have a non-communicating child's pain checklist. And we have like so the vocalizations is our top category. We have social, facial, activity, and then body and limbs, and then scoring that. And again, there will be a link at the end of this presentation with that. So I think that's it for that slide. So when we are considering that maybe our patient is experiencing neuropain, again, this is from Julie Hauer, and this is a screening and some framework to think about when we're considering this in our differential. So again, the inability to be calmed, the intermittent agitation or crankiness without an explanation, chronic poor sleep, and then symptoms that continue after one or more interventions. Like we said, the etiologies of these are often overlapping and contributing to this neuropain. We always want to look at what testing we've done for sources of pain, and then review what we actually can still test for pain. So dental is a huge part that we always want to assess for pain. Hip subluxation, chronic dry eyes, and then renal stones are often also sources of pain for our children with SNI. And then we like to screen for risk of chronic pain due to CNS sources without diagnostic tests. So using the neuro pain risk assessment tool, and then using the score on that to help initiate medication. So now we have the neuropain risk assessment, the NPRAT, and this is our formal assessment tool specifically for chronic neuropain. Any of these categories that would have a level 5, a score of greater or 5, we would initiate treatment for neuropain. So again, we always are wanting to elicit our goals of care, conversations when we're going to be starting treatment or an intervention. Where is our patient in their illness trajectory? What are the patient and the family's goals? And here is a little blip from Julie Hauer again for the introducing the framework of chronic neuropain. And our goals of treating neuropain are often different than treating other symptoms because we don't have that diagnostic testing to perform. So it's really unlikely that the treatment will result in complete resolution of the neuropain symptoms. So just like we educate the family when we're treating the child's pain, you know, we're going to do our best to improve their pain. We may not be able to get it down to a 0, but what's an acceptable level of pain for you to be in? We also have non-pharmacologic management for neuropain. So comfort strategies are paramount. Often the child can be soothed with cuddling, rocking, warm baths, and adjusting feeds is also very beneficial. So adjusting the feed rate and then maybe starting to vent after our feeds, or anytime after large volumes. Repositioning is often another helpful measure, as well as having, you know, supportive bedding and mattresses if we're able to, if we have like a hospital bed at home and we're able to raise the head of the bed or lift up the knees. We have sensory, like weighted blankets, vibratory mats and pillows, and then integrative approaches, essential oils, aromatherapy, Reiki, acupressure, and craniosacral therapy. So when we're initiating pharmacologic management, our first line of treatment for neuropain is gabapentin. And then second line would be TCAs, opioids, and clonidine. Third line, methadone and cannabinoids. So again, Dana Farber has an entire section on neuropain with children with SNI and includes dosing recommendations. So when we are starting these medications, we want to have the gabapentin on board as our scheduled medication to kind of have as our baseline to help control and bring that down. And then we want to have a breakthrough care plan. So that's where our second and third line medications will come in. Often we're thinking of pain sources when our patients are experiencing this neuropain. And so we have our scheduled gabapentin, and then our first line breakthrough may be Tylenol. And if after 30 minutes, Tylenol is not doing the trick, then we may have clonidine as our second line. And then third line could be, you know, back to Tylenol, or you're going to an opioid. Just depends on the patient and what their symptoms are. And a lot of it is trial and error when we are trying to come up with a good breakthrough plan for these patients. We also want to, again, focus on the GI tract and lessen the amount of distension on the GI tract, because that can cause the trigger for pain signals as well. So changing our feeding regimen, slowing down our feed rate, feed volume, and venting after. This does take time. You can, like for initiating gabapentin, usually we're looking at about 3 to 4 weeks until we're reaching steady state and really seeing how the gabapentin is affecting our patient. So always prepping the family that, you know, this will take time, but we would expect improvement. And then just some language strategies for helping to educate the family and give anticipatory guidance. It can be really distressing and overwhelming for the families to see their child in this type of pain, and especially when they're having an acute episode of the pain. So explaining to them, that neuro pain is different than other types of pain, that there is no testing or tools that we can use to confirm that this is neuro pain. Giving them, assuring them that we're going to be checking in frequently, we're going to constantly be assessing, and then making sure that they have a breakthrough plan for pain. And again, the bottom statement, like, I wish I could guarantee that this would be better in a week, setting up that expectation that this is kind of, will take time, and it is trial and error, but we're doing our best to work through this with them. And another resource for families is the Courageous Parents Network. They have really great information on neuro pain, and there should be a link in the resource section at the end of this as well. Any questions on management of neuro pain?
One of the things historically that I wanted to bring to everybody's attention is the very specific language of neuro pain, as opposed to traditionally, we used to call this neuro irritability. And when we use the word pain, I think it's a better description. And this all came from Dr. Julie Hauer, that pain, when we hear the word pain, it makes us act quickly, as opposed to just saying, oh, they're just irritable, or this is just an expected symptom that comes along with severe neurological impairment, irritability. And so really being specific in that transition over many years from neuro irritability to neuro pain has been something that people may give you a little bit of confusion, as opposed to neuropathic pain, which is similar but different as well. Oh, is it my turn to do the case discussion? Am I doing that?
I can do it.
Okay.
All right, so we will move on to our case discussion, and we have 2 today. And reminder, all case discussions are welcome, so feel free to submit any cases that y'all have been experiencing on our form on our website, and it does not have to match up with the topic that we are covering, so submit away. Okay, so our first case discussion is Adam. He's a 6-year-old with relapsed refractory AML. He's no longer receiving chemotherapy and has a DNR in place. He's been declining over the past 3 weeks and is now actively dying. You and your hospice MD have been up-titrating his morphine PCA daily due to moaning and restlessness. Adam is currently receiving 2 milligrams per hour with a 2 milligram boost. At your visit today, you see his parents had boosted him 20 times over the past 24 hours. His parents tell you that the boosting isn't helping his restlessness, and they're wondering what else can be done to make him comfortable. So let's kind of do this together, y'all. And you can type in the chat what your differential diagnosis is, and then maybe an idea on how we can maximize his symptom management. So things that I'm seeing when we're looking at this is that Adam is actively dying. We have been increasing his morphine PCA, and it doesn't seem to be helping with this restlessness that he's experiencing, and that he's had 20 boosts in the past 24 hours with no improvement of these symptoms. So this is where we're going to start thinking that we're maybe experiencing some terminal delirium and using another agent to do that. We can go next. Oh, we have a chat. So Stacy, thank you. She says from an integrated therapy perspective, she'd start with healing, touch, or Reiki, and then ask the team for some Ativan. That's an excellent start. I love that. Again, non-pharmacologic approaches are our cornerstone in treating delirium, so we can always bring those in. And in this case, we started with some Haldol, and Adam got a dose of 0.5 milligrams of Haldol, and he settled down. His parents now feel that he is comfortable. We continue the morphine PCA at the current rate of 2 milligrams per hour with a 2 milligram boost, and then we start the Haldol scheduled every 6 hours with another 0.5 milligram available every 1 hour as needed. We remain in the home to provide the symptom management. And 8 hours later, Adam dies peacefully. And I would add in there that we would be doing some healing, touch, and Reiki along with that. Okay. Any questions or thoughts about that case?
I would just like to point out too, for all of the hospice nurses, that this approach is probably similar philosophically to what your management would be in the adult world, right? You would probably trial Haldol, which I just want to sort of name that, like, your approaches, especially for end of life care, are going to be extremely similar, maybe a little bit nuanced, but very similar to your approach in pediatrics as well. Y'all got this. You already know some of these things. It's just weight-based dosing. And for this guy, he's probably 50 kilos. So he's already an adult dose. So it's the same, right?
Okay, moving on to our second case discussion. We have Carmen, who's a 12-year-old with Aicardi syndrome, which is a rare genetic condition. She has microcephaly, profound intellectual disability, hypotonia, and seizures. She's fed via GJ tube. Carmen has been enrolled in hospice for the past 4 months, during which time her mother Maria has brought up concerns that Carmen has periods of irritability throughout the day and night. We've observed several of these episodes during your visits, and they seem to happen suddenly, although can also occur after feeds. Carmen tightens her extremities, arches her back, and grimaces her face. She can also become tachycardic to the 140s and is difficult to soothe. Carmen's sleep is disrupted by these episodes, and her mother can be up several times at night as a result. Her neurologist has evaluated her for breakthrough seizures, but these episodes do not correlate with changes on the EEG. Her gastroenterologist has started her on omeprazole for reflux and changed her feeds from G to J, but her mom says that these episodes continue. Her pediatrician ordered a sleep study that showed no obstructive sleep apnea. So, any thoughts on our next steps for evaluation? And we can chat them out or unmute yourself and brainstorm together. Allison, visceral hypersensitivity. Excellent. And then Stacy's saying, ask about bowel movements, vent her feeds. So key things that I'm seeing in this case right now is that these periods of irritability can happen suddenly, although they can also happen after her feeds. She's having tightness in her extremities. She's arching her back and grimacing her face. She's having vital sign changes with the tachycardia, and then is having difficulty being soothed, and her sleep is disrupted. And we have already done such a thorough evaluation, checking for neuro sources, GI sources, and then for sleep apnea. So our next, and Dr. Mo says need an appropriate pain scale to further evaluate too. Very true. So our next steps. Chronic neuro pain. All right, Cindy. So when we're moving on to our next steps, we are going to do screening for evaluation of chronic neuro pain. You can hit next slide, Maggie. And so again, this is the from Julie Hauer, and she's meeting a lot of this criteria, right? She's intermittently agitated and irritable. She's having chronic poor sleep. She's having symptoms that are continuing after she was started on omeprazole for presumed GERD. And we have done testing for sources of, for testable sources of chronic pain, and have also obtained an EEG. And so next then, we want to use our NPRAT, which is our neuropain risk assessment tool. When we are walking through Carmen's symptoms, again, I'm sorry if it's blurry on y'all's screen. It is a little blurry on my screen, but moving through this, she has some episodes that are occurring rapidly or out of the blue with no known trigger, so she gets a point for that. She has an intermittent increase in muscle tone, movement, and posture. We said she was tensing and she was arching. She gets a point for that. She is having the GI symptoms. So she's having those pain behaviors with her feeds. And she is also being treated with omeprazole and still having those symptoms. So she gets a point for GI symptoms. And then it is noted that she has chronic poor sleep. So she has 4 points total for her symptoms that she's exhibiting. And then if you go to the top, she gets 2 points because she's met criteria in 4 or more categories. So her total score is then a 6, and we treat anything above a 5. So we'll go to the next slide. So we walk through our NPRAT assessment with Carmen's mom. I think we identified one more symptom that was missed here. So we're giving her a score of 6, indicating chronic neuro pain is a possible etiology for her episodes. And we talk with our hospice physician about starting the medication to treat chronic neuro pain. What medication is our first line for treating neuro pain, chronic neuro pain? You can shout it out or put it in the chat. Gabapentin, yay! That's right. Gabapentin is our first line. And we can go, and vitamin G, that's what we like to call it, for all of its goodness in treating neuro pain for our patients. We can go to next slide. So, like we saw before, we're going to start with our gabapentin. We're going to do a starting dose. And again, this is all referenced in the Dana-Farber Blue Book, but we can start it at 2 mg/kg per dose, TID. And you're going to start that trial over 3 to 4 weeks. You can up titrate your dosing by 2 mg/kg per dose every 2 to 4 days. until a max dose of 50 mg per kg per day is reached. And those are all just general guidelines. Some of our patients will show us that they're having great effect at lower than 50 mg per kg per day, and some require a little bit more. Again, we are treating our patient and the symptoms that they're exhibiting first. And then, of course, we want to make sure that we have, thoughts about our second line and third line. So continuing on, we're starting our gabapentin. That's our first step. Next slide. So we started at 2 mg per kg per dose, 3 times daily in return for a visit. And Mom Maria tells us that Carmen is still having episodes, although she's noticed that they're lasting shorter time. And you go back and talk to your hospice physician to increase the gabapentin to 4 mg per kg per dose 3 times daily with a plan to return 4 days later. At the next visit, when she's at 4 mg per kg per dose TID, Mom says that Carmen's episodes continue to be shorter and now they're less frequent. Carmen's a little sleepier than baseline, but Maria is very pleased and she thinks that she and Carmen are getting more sleep overnight. We continue to slowly up titrate Carmen's gabapentin dose over the next 4 weeks until we reach a dose of 15 mg per kg per dose, which equals 45 mg per kg per day, with sustained improvement in symptoms. And so one of the things I want to point out here is that Carmen's maybe a little sleepier at baseline. You don't have to do equal dosing throughout the day. You can have greater dosing for your nighttime dose to help with that sleep-wake cycle as well. So if Carmen was more sleepy than what Mom wanted her to be and felt that it was affecting her quality of life, then you can adjust the dosing to have, you could do like 50% of your dosing at night and then split 25 a.m., 25 midday, 50% at night. Any question? Yes, and sometimes Lexi's pointing out that sometimes the symptoms can be worse at night too, which would be another indication for the 50% rule. So we can really adjust this and make this a very personalized care plan for our children and whatever symptoms that they're exhibiting. Any other thoughts or comments?
I think too, in addition to everything that that Miss Davis talked to us about, I think that's where like our pain scales become really important, especially like if you're using an RFLAC or whatever pain scale you're going to use, so that we could then, and also like the pattern of behavior that the family has been seeing, so that at each visit you could sort of revisit that to make sure we're going in the right direction. And then the other important thing that I think we already talked about is the importance of anticipatory guidance whenever we're starting any type of medication, so that families can know what to expect and why we are approaching a certain medication initiation in that particular way. So for instance, like Carmen became more sleepy, that would have been a part of your anticipatory guidance with why we do a slow titration over the course of 4 to 6 weeks, for instance. There's also, depending on how severe the symptoms are, you could sometimes be more aggressive. So if they're having like 20 episodes a day, they're awake all night, nobody's sleeping, everyone is just, and we've done this proper workup to rule out other organic causes outside of neuropain or visceral hyperalgesia, you could sometimes be a little bit more aggressive with your titration, with the caveat that the family understands that the most likely side effect would be sleepiness. And we expect that, that's why we could slow that down. Yeah, that was some of my thoughts.
Beautiful thoughts, great additions. Thank you, Dr. Mo.
Oh, and one more is if the kid is less than 5 years old, like Stevie has said, for the most part, 30 mg per kg per day is when we see sort of most children sort of have an effect if they're less than 50 kilos. But if they're less than 5 years old, I've gone up as high as like 75 mg per kg per day, especially for neonates. They're just faster metabolizers sometimes. So that's another thing to just consider, as opposed to some people might switch to pregabalin if you reach that like ceiling dose, which is a different, similar but different to gabapentin. But it might mean that they're fast metabolizers because they're less than 5. And that's also all outlined in your blue book as well.
Great point. And very thoroughly outlined. If we're going down to the resources, the Dana-Farber Blue Book is an incredibly helpful resource. It's written by HPM colleagues at Dana-Farber, Boston Children's Hospital. The link is here, and then it'll also be posted on the website. And just a brief note about it is that it's, you know, updated every couple of years. So maybe, you know, using this as our starting point for the recommendations and dosing, but then going and checking your specific like lexicon for any more updated dosing recommendations. So I think we have a couple of pages of resources because we had quite a few in here. And then thank you all for joining us for our lecture on management of neurological symptoms. I have an incorrect website there, but we are visiting the LMHPCO website for more information about our curriculum, a registration form, case form, session recordings, and then our additional resources. And then please make sure that you complete your surveys to claim your CEU credit. You can always email us with any questions, comments, or suggestions. And our next session will be April 20th, and that will be on ethical considerations in pediatric palliative care and hospice. So spread the word on this great information coming out. And do we have any questions before we wrap up with our mindfulness activity? Anything?
You were so thorough. You answered all the questions. There was one time I went to go type a question and you or Dr. Mo were already answering it. I was like,
great
what is
mind.
that question?
Well, good. And always feel free to reach out, even on email, if something pops up later and you're kind of thinking it through. Always happy to help out and partner. So with that, then we're going to turn it over to Stacy for our mindfulness activity to wrap up this session.
Awesome. All right. Hey, y'all. What I'm going to do today is going to be very simple, but something that you can use for yourself and also with your patients that doesn't take long. So I'm going to give you 3 examples, and it's just a little bit of breath work. We've all done that, but I'm going to give you 3 examples of breathing techniques that you can use, like I said, for yourself and for patients when we're talking about pain. A couple of them are going to have a little bit of guided imagery embedded in them, which can be helpful as well. And we all know with all the pain things, and if you have neurological things, it may not help, but when you have patients who are having pain, or if you're having pain yourself, breathing helps all those medications to work just a little bit better if you can sometimes just take a deep breath. So what I want you to do is just kind of maybe just get your wiggles out. If anybody wants to stand up and get the wiggles out, because we've been sitting for a long time. Because I mean, my buttocks are getting a little bit numb, maybe. And then just take a nice deep breath and settle. And what we're going to do first is this is just going to be like 45 seconds at first. You can just take a deep breath and close your eyes if you're comfortable doing that. And I want you just to tap into how this feels. And for 30 seconds, no, we're going to do 45 seconds. For 45 seconds, I want you just to breathe. Just breathe. Okay, you don't need to open your eyes, but the next exercise that I want you to do is while you're breathing in and out, you don't need to change your breath, but as you breathe in, just count. And as you breathe out, count. So I'm giving you a 1, 2, 3, 4. And if you can visualize that, if that works for you, you can do that. So just counting on your in breath, counting on your out breath. And the last one that we're going to do is when you breathe in a mantra. And I like to breathe in the word calm and breathe out the word stress. Or you can breathe in the word peace and breathe out stress or heaviness. So with each in breath, breathe in, say calm, and with each out breath, breathe out peace. Okay. First, just as you come back, open your eyes, wiggle your fingers and toes. A couple of questions for y'all. How many people felt like 45 seconds felt like forever to just sit? For me, it felt like a long time. How many people felt like, how many people thought that the first one where all you had to do was breathe was easy to focus and breathe? Anybody? To me, that's hard because my mind goes. How many people liked the counting, where you counted in and counting out? Did you feel like that helped your mind to do something different? And then what about the one with the mantra at the end? Breathing in calm, breathing in peace. That's my favorite, and I can change it. So when you're doing, one quick little tip for when you're doing this for yourself or patients, when you're breathing in and out, if you can extend your out breath just a little bit longer, that will access your parasympathetic or your calming the calming part of our nervous system. So if you can make that just a little bit longer, and with the counting, that's kind of easy. With the mantra, not so much. With the mantra, or even with the counting, but I like to do it with the mantra. Literally picture those words calm going up into my brain, picking up all the dramas of whatever stress that's going on. And when I breathe out, literally picturing that just going out with my out breath. I know this is a really quick activity. I like to do that because just to show, like 45 seconds feels like forever. So sometimes you can really just shorten it to 30 seconds. But does anybody feel just a tiny bit more calm after doing it? Sometimes 30 seconds can make me feel calm. 45 seconds can start to make me feel fidgety and agitated. Like, okay, I'm ready to do something. So just keeping those things a little bit in mind, that if sometimes when you're feeling that stress, just to step away and just counting that in and out, or that breathing in and out. I love the mantra, and change it up for, sometimes I even say, I don't know if I can say this, sometimes I breathe in calm and breathe out just craziness. I use different words sometimes too that I probably can't say here, but I want to breathe it all out, right? And breathe in the good stuff. All right, any questions from anyone about any of that? Okay, look, we have some people. Ali said it was so long. Lisa said she liked the counting and the mantra. Lexi loved it, needs some calm and peace. Lisa, yes. She says thanks for helping her bring down her RAS score. Y'all are awesome. I've learned every time I do this, I've learned so much from all of y'all. So thanks again. And again, we'll give y'all back a few more minutes into your day.
Thank you so much, Stacy. All right, everyone. Hopefully we will see you next month on April 20th to discuss ethical considerations in pediatric palliative care and hospice. Have a great rest of your day.
Thank you.